So, and you're going to see it daily, so hopefully you can get something out of this lecture. We're going to talk about OSA and chronic disease, improving health. We do know that sleep apnea produces sleepiness. And we do know consistently that if you treat sleep apnea and the patient can use a machine, the sleepiness go away. Okay? But the thing is that the cardiovascular effects of sleep apnea is what has been a little bit in controversy sometimes with the study that has been coming up. So what I'm going to talk about is OSA basics, prevalence. There are some new studies that have updated the prevalence from the studies from the 80s and early 90s. We're going to talk about chronic cardiovascular and pulmonary disorders associated to OSA. And then we're going to see what can you tell your patients about the CPAP. Okay, they're going to come and ask you, do I really have to use this? Because you send them to me, and I'm pushing it. So, and I send them back to you, talk to your doctor. Okay, so let's say what we're going to say. Okay, so prevalence in the 80s, in the late 80s and 90s, the studies show how many males have a sleep apnea with HI more than 5, not with sleepiness, with third year here. How many male patients have OSA? If I got 100 males, how many are here? Okay.
Like 20%.
Around 20% without the sleepiness. How many females? 5%, 4%. Okay? That was what described in 89, in the early 90s with the Wisconsin cohort and the sleep heart health studies. Okay? But now, what's going on with the population in the United States? Are they getting thinner or bigger? Bigger, no? We're getting to a plateau, it looks like. So hopefully that will go in the other direction. But we're increasing in obesity. And that's one of the main risk factors to have sleep apnea. So in this epidemiological study, what they did is that they adjusted the prevalence of OSA based on the increase in weight. What was the average BMI? I told you this all the time when you read with me nocturnal oximetries. What was the average BMI for patients in the late 80s, early 90s when they did the studies? Less than 25, between 25 and 28, 29 to 30, or more than 30?
25 to 28.
29. Okay, so they were much thinner. Okay? What's the average BMI in the country now? 33. What's the BMI in Henry Ford Hospital? 33. Okay, so if you look at that, then you can see the prevalence in males with an HI more than 5, depending on the different ages, 30 to 49, 50 to 70, and 30 to 70, was around 20, 38, 26%. Now, if you adjust for the weight changes, it has increased to 34%. So you see the AHI in there has increased, okay? And so a third of your patients have it, a third of your male patients. And if you look at females, it used to be 13% when you look between the age of 30 and 70, and now it's 17%, okay? So it's very important that you consider that. Now, what about pathophysiology? What happens in non-REM sleep? Why do we always talk about sleep? You sleep how many hours? Hopefully 7, no? 7.5 is another recommendation. Yeah. Let's just say you're 7. Okay. So suppose it should be 7.5. That's a new recommendation, no? I still recommend 8 because I think it has some validation in there for some patients. They feel better with 8, it's good. Not everybody is feeling better with 7.5. Some people say they can sleep with 5 hours and they're fine. Some people need 9, okay? But normally, non-REM sleep, your sympathetic activity goes down, your blood pressure goes down, your heart rate goes down. Who has read studies with me? Abdul. Okay, you know? So what happens in non-REM sleep and delta sleep? How is the breathing? How's the flow? Very regular, no? What's the heart rate? And what's the blood pressure? Regular. In non-REM sleep is very regular. The blood pressure goes down. What happens in REM sleep? It goes up. You have more sympathetic activity. Your heart rate goes up. your blood pressure goes up and down, your oxygen consumption goes higher. So how much of REM sleep do we have? 20%, and if we get older, a little bit less, no? Okay. So normally, the majority of your sleep decreases your heart rate, decreases your blood pressure. So what happens in a sleep apnea? So sleep apnea happens for different reasons. It's not just the weight, because there are people with ideal body weight that will have a sleep apnea, no? But there is a problem with respiratory control. Some people tend to hypoventilate or hyperventilate. So if you overdo it or do it too little, you can have a sleep apnea. Obesity is another factor. As you gain weight here, you gain weight in the neck. When you do studies in rats that are obese, the tongue gets very thick, and that makes them more propense for apneas. And then the upper airways dysfunction. So some airways are easier to collapse than others. Okay? So if you have an airway that anatomically or functionally tends to collapse, you're going to have more apneas. So what happens with sleep apnea? You have problem with your sympathetic nerve activity. What is the most common arrhythmia in sleep apnea? No. What? I heard something. Tachybrady. Tachycardia. When do you have the tachycardia? At the beginning of the apnea or at the end of the apnea? At the end of the apnea. Okay, so then you have metabolic dysregulation. There are studies that show that there is poor insulin resistance, problem with insulin resistance in patients with sleep apnea, and when you use CPAP, that improves your insulin sensitivity. Inflammation, there is increased C-reactive protein, and all the TNF and interleukin-6, all of those go up. That's why it's related to what pathology relates to obesity and sleep apnea? Asthma. There is a lot of literature coming out with that, no? And then there is oxidative stress. What is worse, to have COPD with persistent hypoxia or to have the oxygen going up and down, up and down, up and down like this? What is worse? What kills more pancreatic cells? Going up and down, because you have oxidative stress, you have too many oxygen radicals going up and down. And then there is vascular endothelial dysfunction. And my theory, and I think people are thinking about it, if you have somebody with OSA or OHS that for long term, many years, is hypoxic, at some point there will be some changes in the endothelium, in the pulmonary vasculature that won't change. So you send me a patient and we're hoping that with CPAP or BiPAP it's going to get better, and it doesn't get better. You just can't reverse it. Think of how many years they have been like that before they come to treatment. And then intermittent hypoxia, again, we talk about it. So that all can give you heart disease, high blood pressure, atrial fibrillation, okay? You're trying to control your heart rate at night, and they're going up and down like crazy, so you can give them all the beta blockers you want, and they can have recurrence of atrial fibrillation despite ablations. We'll talk about that in a minute. So, and then you have end-stage cardiovascular disease. At some point, yes, I can improve the sleepiness, but I might not improve the pulmonary hypertension, okay? So it's good to diagnose it early than later. So this is an example of a sleep apnea of an epoch. You have the EEG channels on the top, EKG, the thermocouple for apneas. What do you use to detect apneas? The pressure sensor or the thermistor? Thermistor. And what do you detect better with? What do you use to detect the hypopneas better? The thermistor or the pressure sensor? Pressure sensor. Very good. So you can see that when you have an obstructive apnea, your saturation goes down, your CO2 goes up, okay? And that happens 100 times per hour, 60 times per hour. I mean, you just think about it, that you stop breathing 30 times per hour. That's the maximum, no? What about if we see 120? How many do we see? 150? 140? So it's a lot of many times of that. Yeah, so practically you don't sleep. I mean, they breathe for a little bit. When they're awake.
What's the
Okay.
What's the thermistor? Is that the sensor?
Yeah, there are two sensors that you put in the nose. One that goes like in between on the nose and mouth, like a metallic thing that senses the changes in temperature, and that's more is the best for apneas. And the pressure sensor is like a nasal cannula, but very long, that senses changes in flow, and that's better for hypopneas. So you tend to underestimate hypopnea with a thermistor. So that's why we use the two sensors. So when you have a sleep apnea and recovery, you can see here that all the different pathophysiologic mechanisms that are going to give you either increased heart rate, organ dysfunction. There is more relationship of hypoxia with renal failure, okay? It's going to give you increased blood pressure, arrhythmias, and then problem with left ventricular afterload. You're having increasing swings of pressures inside your chest, so that's going to give you problems with preload and afterload. So that's very important for heart failure management. So this is a table that tells you also some of the cardiovascular disorders that are having related to OSA. So you can see in there, depending on what you are reading, 30 to 83% of people with hypertension are going to have OSA. 38 to 65% of people with coronary artery disease are going to have OSA. 57 to 75% of people with a stroke. 12 to 55% of people with heart failure. And 20 to 50% of people with arrhythmias. Aortic aneurysm, 40% of them have that. So can you imagine if you're snoring very loud and your aneurysm is doing this, and it's getting loud like this, okay? So that's not good. That's not good for your aneurysms. So these are all the pathologies that you already know have been associated with sleep apnea. Sudden death as well. Sudden death tends to happen when? Between midnight and 6 in the morning the majority of the time. So that's why people think that sudden death and sleep apnea might be related. And it happens mainly when the patient is saturated to 40 or 50%, which we see in the laboratory. How effective is your nocturnal oximetry to detect hypoxia under 70%? If something is under 70%, it's not good. You just don't know what else is under that. They are not built to detect very well exactly how much is your saturation under 70%. It's just bad enough, so that's it. They stop there. Okay? So it can be 20% what we're seeing in the lab. So this study, there are a lot of other studies, but I'm just putting some of the new ones. This study relates, it's a study from Australia that looked at 200 patients that were followed for 20 years with OSA. And you can see here all mortality, all-cause mortality, and in the green you have moderate to severe sleep apnea, which is more than 20 events per hour. And you can see how the mortality is higher in patients with OSA. There is new literature coming out with cancer. There are more patients with cancer when they have moderate to severe sleep apnea, and the mortality related to cancer is higher as well. And then you have the incidence of a stroke. Persistently, a stroke comes up. You know, you are going to read some papers, and they're going to say, "Oh, we didn't find the relationship with coronary artery disease, or we didn't find it with heart failure," but consistently, you will find a stroke. Okay? And females tend to be more protected than males. It's a little harder to find increased mortality in females or increased heart failure in females. So this is another study. Who likes pulmonary hypertension? I think it's fascinating. But we don't have much to do, but I think it's fascinating. So this is a study that looks at OSA and how that can affect right ventricular failure. So this is just OSA, this is not OHS. What are the criteria for OHS? I always find somebody who doesn't know the BMI. What's the BMI for OHS?
30.
30. Everybody talks about 35, but it's 30. Very good. What's the CO2? 45. Okay. Do you have to have do you have to have apneas for OHS? No. How many patients with OHS do not have apneas?
10%, roughly.
10%.
So that will be good sleep.
Where is Dr. Tatum? Okay. This study have done a lot of measurements in right ventricle. In the right ventricle, there are different measurements that I'm not doing anymore. But it does show that there is significant changes. When you have significant OSA, your right ventricle starts to either dilate or your right ventricular wall starts to get thicker. Okay? So whatever the measurements, all of them are showing changes in the right ventricle. And in this study, they look at how many patients with OHS actually, how many patients with OHS. And the truth is that we don't check ABGs in everybody with a BMI of 30, no? I'll be checking everybody in my clinic. How much is, I always say that too, how much is the cost of an ABG? It's a little high. $300. An ABG is $300. It might be more now. Who knows? This is when I check it, but you might know how much. It's $300 when I checked it 5 years ago, and I always repeat it might be more now. So maybe now inflation, you know. Maybe, who knows? If you want everybody could take it, and so it's a lot of money to check an ABG in everybody. Okay, but if you do and you find OHS, this study looked at 77 patients with OHS. And they didn't even look at what is the pulmonary artery pressure that indicates pulmonary hypertension? 25, very good. And how much with exertion? It changes with exertion, no? 30. Okay. So they actually look at a systolic pulmonary artery pressure of more than 40, just to make it more accurate, okay? Because 25 to 30, you cannot look at it, you don't look at it. No, but more than 40, you pay attention, no? And in 53 of the 77 patients, they had elevated pulmonary artery pressures, more than 40. And the mean was 64 plus minus 17, so it's pretty high. It's very, very high. I don't check an echo in every patient that have OHS. Should I? Maybe I should. Okay? And what kind of ABG what kind of CO2 should I use? I normally check an ABG in patients that have a BMI more than 45. Because if not, I'm checking everybody. So maybe looking at what group will be better so we can tailor the treatments. And then it's also more frequent, it's very frequent in men and females, but it's more frequent in females. 71% of the females with OHS have pulmonary hypertension. And the problem is that I have patients that I started very nicely on BiPAP and they're using it and I can't drop it anymore. Because they had a hard time using CPAP for years, so they have 1 study, 10 studies, they try. Finally, we got them to use BiPAP, and after 15 years of treatment, we just can't reverse the pulmonary hypertension. Okay? So this is another study, acute cardiogenic pulmonary edema. They look at, this study just came out in chest. They look at patients with acute pulmonary edema in 3 centers, and they did, after they stabilize them and they diurese them and they gave them all the medication that they have to give them, they did the sleep studies and they pull all the patients with an AHI more than 15, okay? They followed them for a year, and this study was done in Brazil, so they were not treated with CPAP. They don't have insurance, they can't afford it, so they just observe them. That's when the benefit of being in Brazil, you don't have to worry about it. They don't have the money. I mean, that's it, you know? It's terrible. But anyway, they just observe them, and then they look at, if they were 104 patients, 61% of them had OSA. So you can see here the distribution of admission times. The majority of the ones that have OSA in the gray, the majority of them have admissions in the night, between midnight and 6, okay? And then they look at all-cause mortality, and all the patients, the 17 patients that died had OSA. It's a sad case, no? At least here we have to put everyone in CPAP and try not to, but they just have to observe what happened. So that's the natural history of OSA and heart failure. And they also have more readmissions. They have more non-fatal MIs. So it's a... And then they look also at recurrence-free survival. If you don't have OSA, you have less amount of recurrence, less amount of infarctions, less amount of mortality in the red line. Okay? So the question is, okay, so we know that OSA looks like hurts you. Now, if I treat it, does it make you better? And that's where everybody is worried, no?
Okay, so I think most
most of the studies like excluded patients with AHI 5 to 15. Like that, is there good evidence for these comorbidities in patients with mild OSA, or is it all OSA patients?
If you look at, there was a study that looked at females that had normal overall AHI, and the REM AHI was abnormal, was more than 15. So overall it was normal, but the REM AHI was high, and they still had higher chances of cardiovascular disease. So it's a one-to-one, because your problems with, it's stronger the mortality with an AHI more than 20, it's stronger the stroke with an AHI more than 20. But the brain is observing long enough to find that. But so far, we are recommended to treat 15 and above, unless you have cardiovascular comorbidities already, and then you treat that. But it's a one-to-one ratio, like if you have a one event per hour more above 5, you have a 1% more risk of having hypertension. So anytime you increase your AHI, a little bit higher is your risk of hypertension. So CPAP and hypertension, talking about that. So in this study, we look at the effect of CPAP this is for net reduction of blood pressure. And you can see that in the blue is the systolic and in the red is the diastolic, and it drops, depending on the study, between 4 points or 3 points up to 2 points. 2 to 4 points of changes in your systolic blood pressure or diastolic blood pressure, okay? This is another study that looked at resistant hypertension. So if you have resistant hypertension, more than 3 medications, they look at how many of them have OSA, and it's very high, it's around 50 to 60%, depending on what you are reading. And the changes are even more dramatic. You can go from 9 points to 10 points to 12 points changes in the systolic or diastolic blood pressure. And that is consistent. Now, we do know that if you reduce your systolic blood pressure by 2 to 3 millimeters of mercury, you can reduce the chance of a stroke by 4 to 8%. This is with medications. So that can also be applicable to CPAP. The CPAP is limited by a lot of things. You know, the main mechanism through what OSA produces increased heart rate and increased blood pressure is going to be the sympathetic response that you have with the apneas. So that's what you're working on with the CPAP machine, trying to decrease that part. Your epinephrines are very high. They have done tons of studies checking epinephrine in the urine and stuff like that. But there are other mechanisms for high blood pressure. The patient by itself, obesity by itself can give you more blood pressure, not necessarily with apneas. You can have also problems with diet. And if they don't take care of that, you just cannot handle it. So there is a lot of confusing factors when you do studies to be able to see the effect of CPAP. And again, the remodeling of the vascular endothelium is a problem. You know, at some point it's going to be fixed and you cannot change it. Now, what is consistent in all the studies, and we're going to talk about the studies that came out in the last 5 years, which question the effect of CPAP on hypertension, is that when we always ask the patients to use the machine at least 4 hours, no? And there is a reason. Because all these studies that show improvement in high blood pressure, all these studies that show improvement in stroke risk, is when you divide the groups in compliant and non-compliant groups. So if you use your CPAP more than 4 hours, or 4 or more, you have decrease in risk. If you use it less, there is no decrease in risk. So that's important. But if you look at the literature in resistant hypertension, if you use your machine by 1.9 hours more at a time per night, you reduce your systolic blood pressure. For every additional hour you use a CPAP, you reduce the systolic blood pressure and the diastolic blood pressure by 1.9 and 1 millimeter of mercury per hour that you use. So they compare 2 versus 3 versus 4 versus 5 versus 6. Between 4 and 6 is the magic number, somewhere in there. More than 4, at least 6. I don't know if ideally is 5, 5.5, but at least more than 4. And obviously you have to combine things. It's not just CPAP, no, you have to use weight, diet, medications. So this is another study that came out with losartan. Okay, they look at losartan in patients with OSA and patients with no OSA, and after adding CPAP, does that help? So in the first square here, you have patient with no OSA. This is the systolic blood pressure. This is the diastolic blood pressure. And this is at baseline. This is the systolic blood pressure, and this is the systolic blood pressure without losartan and after 6 weeks of losartan. And the patient with OSA do have a drop in the blood pressure with losartan too, but not such as well as patients with no OSA. Okay, and it's also true for patients with for the diastolic blood pressure. But when you add the CPAP, then the pressure drops even farther in patients with OSA. So yes, your medications are going to work in patients with OSA, but they are not going to work such as well without the CPAP. So it's important to use that. So this is, now we're going into there were 3 randomized controlled trials, and there has been a lot of meta-analysis done. That there was one that just came out in JAMA, which is terrible. But I will, hopefully, I didn't put it here, but these are the 3 main randomized controlled trials for OSA. You have the BARB, the CIRCAS, the RICATSA, and the SAFE study. The SAFE study is the biggest one that has like 2,717 patients. So all of them show that when you look at the whole population, all the patients on CPAP, whatever the usage is, there was no difference in cardiovascular risk. But when they separate the groups and they put them more than 4 hours versus less than 4 hours, there is a favor, it favors decreasing cardiovascular risk. So for the BARB study, it's a study that entered 725 non-sleepy patients. This is the other thing, like if you're sleepy, and the sleepiness doesn't correlate with the severity of the apneas. You can have somebody who has 5 events per hour and is very sleepy, and you can have somebody who has 120 events per hour and comes and tells me, I'm not sleepy, why do you want me to use this? Okay? So this really doesn't correlate much with the apnea index. So in all these studies, because of ethical issues, they didn't include patients who are sleepy because they can crash the car. No? So that would be another reason for treatment. So they excluded those. So in the first study, they had 725 non-sleepy OSA patients with AHI more than 20. The Epworth score was less than 11. They didn't have any cardiovascular disease, and they treated them and followed them for 4 years. And they didn't see any cardiovascular benefit in between the 2 groups, but there was a poor compliance group too. Overall, their compliance was around 3 hours. So when they separated them for compliance more than 4 versus less than 4, there was improvement in cardiovascular risk. The next study had also patients with OSA, 244 with HI more than 15, again not sleepy, less than 10. They just had coronary heart disease, and they had revascularization, and they put in an auto PAP versus no PAP, and there was no difference, but again, once they divide them by the compliance, there was a difference in cardiovascular risk. And the cardiovascular risk that they are looking at is readmissions for another MI, for heart failure, or for another need for another stent or stroke. That's kind of the average what they look at. Now this study, which was very nice because it had 2,717 patients, was really questionable. I don't know how it could get published in New England Journal of Medicine. I was very surprised. But they got in there. So, first of all, they didn't do sleep studies on these patients. They did like an oximetry and a cannula. Okay? How can you differentiate with an oximetry somebody has OSA or central sleep apnea? Can you? No. What do you need? You need a polysonogram. You need the effort channel. No? So they just they put everybody on practically an oximeter, and they choose all the patients that have an ODI more than 12. Okay? And those patients, they assume they had sleep apnea, and they put them on CPAP. They were kind of not too sleepy. The Epworth score was 15, age 45 to 75, and they followed them for 3.7 years. And then the average usage in the whole group was 3.3 hours. And again, all the literature, even before those two studies that I just talked to you about, show that you need to use it for 4 hours or more to have improvement in cardiovascular risk. So overall was 3.3. And when they did this, when they look at the results, they said, oh, there is no improvement in cardiovascular risk again. So first of all, they didn't have a study, so we don't know if they have obstructive apneas or centrals, because they all had some cardiovascular event, so who knows. They excluded all the patients with hypoxia, significant hypoxia. And you have seen nocturnal oximetries. How many patients have very little hypoxia when they have how many do have a lot of hypoxia? And you can see that they desaturate a lot. So they took the milder patients, the ones that desaturated only for 10% of the night under 80%, which is just maybe 30 minutes, the most, okay? The majority of the patients were Asian, so, and they excluded the sleepy patients, the very sleepy patients. So they are having a very population that has milder disease, and that's why they couldn't find effects. Again, when they separated the patients and they look at the 561 patients that were compliant and compared it with the other group, there was a significant decrease in the stroke risk. Again, a stroke keeps repeating in there. And they also look at quality of life, Epworth score, and different things like that, losing job hours, etc. And there was an improvement in the group that used the CPAP, even if they didn't use it for 4 hours. Okay. So there are a lot of questions with this, but again, it repeats: more than 4 hours, you do a better job. So, with respect to stroke and TIA, the American Heart Association and the American Stroke Association, in their guidelines, recommend a sleep study might be considered for patients with an ischemic stroke or TIA on the basis of the very high prevalence of sleep apnea in this population and the strength of the evidence that the treatment of sleep apnea improves outcomes in the general population. So that's one of the recommendations from the guidelines, okay? Now, what about pulmonary hypertension? So 10% of the patients with OSA are going to have pulmonary hypertension with a PD pressure more than 25. So there is a study that used a CPAP for 12 weeks in patients with pure OSA, and you can see the mean going from 30 to 24. If you have a patient with OHS, and the patient uses the CPAP or BiPAP in this case, I have had nice successes. But it is very nice to see that you can get them off oxygen, they can walk, and they can go back to work. Okay? So it really works if you really target to improve the apneas and the CO2. You really give them the right ventilation to expand their lungs. So because of that, the American College of Cardiology and the American Heart Association consensus recommends to do a polysomnogram to rule out OSA for all patients with pulmonary hypertension, since targeted therapy of OSA could either improve or prevent further deterioration in central hemodynamics. Okay? So CPAP and arrhythmias. So the majority of the studies in arrhythmias are observational. We don't have really good randomized studies. But in this study, they look at a very big group of, it's a meta-analysis of many studies, and they were able to collect over 3,700 patients with AFib. And they look at the risk of recurrence after ablation. So if you have OSA, treated or not treated, they put them all in one group. They have a 31% higher risk of atrial fibrillation recurrence after ablation. If you have OSA and you separate the subgroup of no CPAP therapy, is 57% risk of recurrence. And if you have OSA with CPAP, the recurrence is 25% risk, which is the same as the risk for patients that don't have OSA. So everybody that goes through an ablation can have recurrence, but you're going down to the same recurrence of somebody without OSA. Okay? So this is just the table. And then looking at heart failure, so here, depending on the study that you are looking at, you know they changed the name and now it's heart failure with preserved ejection fraction and reduced ejection fraction. So in this nice table, they put several average of studies that tell you the the amount of obstructive sleep apnea and central sleep apnea in this type of patients. So you see that obstructive sleep apnea is very prevalent in central sleep apnea in heart failure patients. Diastolic more, systolic less, but still in a quarter of patients might have obstructive sleep apnea. And then central sleep apnea obviously is higher risk in patients with decreased ejection fraction. If you have a lot of the medications that we're giving them to control heart failure are supposed to decrease the sympathetic response. Now you want to decrease the heart rate, the blood pressure, and everything that apnea does is completely the opposite. No? So that's, if you look at the table in heart failure, you have, if you have an apnea, you're going to produce hypoxia, that's going to produce sympathetic response. The arousal is going to produce sympathetic response. If you have central apneas, there is also the vagus nerve is going to stimulate the breathing so they can go up and down and have more chain stalk breathing. So it can be combined. So in this study, this is 30,000 patients. It was a review of Medicare patients. 30,000 of them that were not tested with a sleep apnea versus 258 that were tested. And you can see that the percentage of the mortality is lower when the patients are diagnosed with a sleep apnea compared to the ones that were not even tested. Because if you are tested, hopefully they will put you on treatment. They couldn't really check all that, but if you were tested, they could put you on treatment. So they're assuming that they were on treatment, and that helped the mortality in these Medicare patients. But that tells you, too, that out of a lot of heart failure patients, only 1%, I don't know, how much is that? A tiny little bit is checked for a sleep apnea, even though the frequency is extremely high. So then the other thing that you might have in your boards is the central sleep apnea therapy. And there was a study that came out in 2015 that revolted all sleep medicine because we had patients on ASV right and left. ASV is a beautiful machine. It's a bi-level machine that learns how the patient breathes, and if the patient is hyperventilating, drops the pressure support. If the patient is breathing very shallow, increases the pressure support, so it can give you a perfect resolution of central apneas and obstructive apneas. It's really a nice machine. But so they wanted to know, okay, if we're treating central sleep apnea well and we're controlling the apnea index so well, let's see if the ASV therapy improves mortality. So they got all these patients with heart failure, ejection fraction less than 45%, and they put them on ASV if they had central apneas. But what they found is that with the ASV machine, there was increased cardiac mortality on these patients, especially when the patients have a ejection fraction less than 30%. But when they told us to recall all the machines, they decided to use the inclusion criteria, which was EF less than 45. But in the subgroup that really had problems was less than 30. And the reason was, if you look at the studies on CPAP and cardiac output, the positive airway pressure can decrease your cardiac output. So if these patients are depending a lot on their right-sided function in the preload, and you decrease the cardiac output, then they can have problems with poor cardiac output, worse than they were. So they have a very frail situation, so they tend to have problems with that. Now there is some theory behind it that they said maybe CSA is a mechanism to help heart failure. But it just have all the other controversies of sympathetic discharges as when with obstructive sleep apnea too, so it's not very clear that. There is some literature that is showing too, you might find those studies where, patients with OSA and hypoxia, they maybe have less amount of MI in the hospital. And the idea is that behind that, because they have been having hypoxia all the time, they are having more extra vessels. They are opening more vessels in the tissues, and they are having better, they have a little bit more reserve for circulation, because they are just pushing their vessels in there so they can open, okay? Anyway, for this, just in your boards, ASV is contraindicated in patients with heart failure EF less than 45%, okay? Any questions? Yeah.
the problem was pressure, why wouldn't any sort of PAP therapy be contraindicated?
Oh, well, because they have done studies with CPAP, and CPAP doesn't increase the mortality. That's a very good question. There's another study. This is what their theory is, because they don't really know. So their theory is that maybe in the patients with very low cardiac output, we were making it worse with the pressure. So they are blaming it on the way the pressure is pushed by the machine certain times of the night. In CPAP, you don't go up and down in pressure. In CPAP, you just give them 5, 6, 7. It's not, and the other one can go up to 17. Well, because they can go up to 17 on BiPAP. This is a BiPAP. So it can be 17 over 5 some periods of the night, or it can be 0 over 5. So it can be really high. So that's why they were thinking that that maybe is the reason. But they don't really know, because there is a Respironics version of the machine, and they haven't seen yet mortality increase. So they are waiting for those results to come up. They think it's maybe just the type of machine or the way it's pushing the pressures. That was their explanation. There are studies when you use, for example, in COPDers 25 over 10 and so forth, you can look, you can do right heart and your cardiac output drops a lot. They don't feel it because their heart is still okay. So if they were able, those pressures can go to 19 over 5, very big deltas, maybe that's what did it, instead of having just a steady pressure through the whole night, which is what we do with CPAP. Or BiPAP. BiPAP ST doesn't go up and down. BiPAP ST is just one steady pressure all night.
You're using AutoPAP now, and that certainly changes, right?
Well, but not for central, not for heart failure. Not for heart failure, only for obstructives. So in conclusion, what we can say, like if your patients tell you, I don't want to use it, okay. So there is high quality evidence about the relationship between OSA and hypertension, and that CPAP really drops the blood pressure. Nothing has said the contrary. So I think for hypertension, it's fine. It's already very, very established that if you treat OSA, that can improve your blood pressure. The problem is for the other cardiovascular events, such as a stroke, heart failure readmissions, arrhythmias. What we do know consistently is that if you use it more than 4 hours, it prevents those events from happening as a primary prevention or as a secondary prevention once you have had coronary artery disease. And so far, the available evidence for arrhythmias is more related to observational studies. So we need more randomized studies to really say in arrhythmias what we have to do. But because of the pathophysiology, normally the cardiologists or the EP guys like to treat those patients. So that's kind of where we are, and we need more randomized controlled trials, Any question? Yeah.
So, about the varying literature on CPAP and hypertension.
Yes.
So, ASH, like the Society of Hypertension, as well as ASN, yes, we do refer for sleep study and we encourage its use, but based on collective evidence, at least most of our practice has been to tell them that don't expect your blood pressure to improve.
Yeah.
Is that something you would suggest not to say?
I think in some patients it improves and in some patients doesn't. We see it all the time. I have some patients, and not everybody, that, it looks great, and some patients that doesn't do a thing, and they are like, I thought that was going to drop my blood pressure. So I think that's why they also tell you there is a group of patients that it doesn't matter what, we don't know if they are taking their medications, If they are perfectly compliant with CPAP, my feeling is that they don't take their medications either. The obesity, the diet, all of those things are something that we cannot control in clinic. You can control it in the study, like losartan, for example, they control everything in that study, but you don't control it in the clinic. So that's the problem. And I do believe that there is a moment after 50 years of OSA, they say they started at 20 and they come to me in age 65. I mean, how much of that vessel is going to be like just fixed and not reversible, no? I think it would be nice to find out early if you start to treat them early. That's what they're doing in kids now. They are doing studies in kids where they are deciding, we don't know if 1 should be treated or 5. We are more in the idea that 5 ml per hour in kids is what we have to treat. And they're observing kids now to see what's happening with blood pressure and cardiovascular disease. And then that's going to maybe give us more ideas what time, how many years they have to be exposed to OSA before it's not reversible. Worth it to try though. They will feel better. Yeah.
So I was surprised the other day to find, and I don't know if I think it's right, that when you put patients with OSA on CPAP, they gain weight initially.
Yes, they do.
Is that something that they gain weight enough where the settings have to be changed later on, or is it just like a minimal weight gain, like smoking cessation weight gain?
I think it's a habit. You know, sleep apnea is not just putting you in the treatment, it's also talking about diet, exercise, and if they are not doing that, they're going to gain weight. One of the theories in that article was that maybe they have more energy and they go eat more because they just don't have, instead of going to exercise, they go to the restaurant, you know? So that's a problem. They don't use the energy in the right pathway, they just have bad habits, and this. I actually tell them that just be careful because you might gain weight now that you're going to be more awake, because the studies don't show the contrary. And also,
I mean, Dr. Bazan, isn't it also because like now we've gotten rid of the metabolic stress that they undergo every night due to the sleep apnea, the apneic episodes, the tachycardias?
they think the oxygen consumption, the metabolic stress may be less, so that's why they can be maybe, I don't know. I don't think I have read anything about that part, but it's possible. If you look at their oxygen consumption when they are waking up constantly and not resting versus after they're in treatment and they maybe spend less amount, it's possible. I haven't looked into that, but we can try. We can look at that. Any other questions? I didn't put here COPD and OHS because it's very long. And I think, but you know, OSA and COPD and the overlap syndrome is very important to treat. If you treat, the literature says that if you treat COPDers that have OSA with BiPAP, there is less amount of readmissions, and your CO2 gets better. So it will be important to try that. Plain COPD is different. There are some studies that show that observation now, you know, that there is increased readmissions for COPD. But we're still not very sure about complete about mortality. There is one that came out that says in 2014 that says mortality is better, but it's still not completely randomized. But some of the patients that you send me don't come back, but they have to use high pressure. So the problem is the tolerance. You know, the main problem for CPAP and BiPAP is tolerance. Using a mask is cumbersome. You know.